Hello, ladies and gentlemen. I'm Daniel Montano. I'm the Chief Executive Officer of Angiogenesis Medicine. We're here today for our number 2 webinar, which is on coronary artery disease. Dr. Jack Jacobs will be giving the formal part of the presentation. And as you can tell, we're still learning how to do Zoom presentations. So I'm going to give you an introduction to what we're doing. Dr. Jacobs is going to give you the information on the coronary artery disease treatment that we have, and then I'll have some concluding remarks. Our company, Angiogenesis Medicine, is a biotechnology company. We are developing a biological drug which we believe can treat the diseases that are responsible for over half of all the deaths on Earth. Today, we're going to be talking about coronary artery disease, which is the leading cause of death in the world. And it is the crown jewel of Zhitya's portfolio, which I will talk about more in a moment. What I want to talk about right now is what is Zhitya's business? Zhitya's business first is discovery. As an example, we have discovered that this molecule can trigger the growth of blood vessels in the human heart. This started from February 28, 1998, when I was reading the Wall Street Journal, and there was an article there written about a publication, the Circulation, which is the American Heart Association's publication, about doctors in Germany triggering the growth of blood vessels in a clinical trial. I read the story, I looked at it, and I know that heart disease is the #1 cause of death in the world. And my business partner of 25 years had had his second triple bypass and was now a no-option heart patient. So the following week, I went to Germany, acquired their rights, and started this process of discovery. So Dr. Jacobs and I have been at this for over 22 years. So discovery is, how does the drug work? Why does it work? What are the medical indications? What are the side effects? What are the risks? How do you apply it? And what are the results that you get? And that's part of what Zhitya's business is, discovery. And after that, the next part is to carry out the clinical trials, to generate the evidence, to give to the regulators, to seek approval of the drug. So as an example, Jack is going to show you a lot of the clinical trials that we've done on the heart disease. Once again, our crown jewel in my mind. We're going to show you animal trials data. We're going to show you human trials in Germany. We're going to show you human trials in the United States under the FDA flag. I believe we've done 3.5 clinical trials. Jack only talks about 3 because the last trial we were not able to complete because of the financial crisis. And that is the design and carried out the clinical data. Then we have to obtain regulatory approval, and we have to then commercialize the drug, which is another issue. But this presentation is on coronary artery disease. Now, I want to do 2 things. First of all, if you have questions and you want more information on the basics, how does the molecule work? Why does it work? How do you grow blood vessels? How do you not grow blood vessels? We've created this booklet, which is something that you can all obtain by emailing me at dan@zgm.care. This talks about the heart disease, stroke recovery, Parkinson's, multiple sclerosis. It gives you the fundamentals of our drug. And this small booklet has a tremendous amount of information. And we basically prepared it because so many people didn't understand the basics of what we're doing. Additionally, on this topic of coronary artery disease, Dr. Jacobs has written a white paper. And this is the breakthrough treatment of severe coronary artery disease using our FGF1 molecule to treat coronary artery disease. Now, before I introduce Dr. Jacobs, I want to go through something. Most people believe that coronary artery disease is a well-treated disease. If you have heart disease, there's a bypass, there's a balloon angioplasty, there's stents, there's statins, there's this, there's that. And I disagree completely. 80% of the people who suffer and die from heart disease have a form of heart disease called small vessels heart disease. This affects more women than men. It affects 80% of men. But if you're Hispanic, if you're Oriental, you have a disease where the heart, your arteries that get blocked are not the big arteries, it's the capillaries in the arterioles. This is the most killing form of heart disease. It's not one massive heart attack where the person bends over and falls down as you see in the movies. It's the fact that a small area of the heart has insufficient blood flow, and that small area goes into hibernation and then death. And slowly but surely, the heart fails because there's dead scar tissue throughout the heart. To my knowledge, we are the only treatment for that. To my knowledge, we are the only hope for 80% of the millions and millions of people that have this condition of heart disease. It's called no option heart disease. Women go to the doctor, they complain of heart disease, they run an angiogram and they say, we don't see any blockage in the major arteries. And slowly but surely she dies of heart disease until she has congestive heart failure. We're the only treatment. So I believe that this is the #1 needed medical therapy in the world, bar none. In the United States, it's estimated 10 million people have angina. And I believe 8 million of those people suffer from a form of heart disease that only we can treat. So this is our crown jewel. We have 3.5, in my opinion, only 3 in Jack's opinion, clinical trials completed where we know the molecule was safe, delivered results, and the people who got the drugs' lives improved materially. Now, Dr. Jacobs is going to give the medical and clinical part of the presentation. I have the honor now of introducing Dr. Jack Jacobs to you. Dr. Jacobs has been my partner and friend now for 22 years. When we started this journey, and I came back from Germany, I was asked, who's going to actually do the thinking, who's going to do the molecular biology, who's going to do this and that. So I found one of the leading experts in the country, Dr. Ralph Bradshaw at University of California, Irvine. I met with him, I told him my problem. He says, you need to hire Dr. Jack Jacobs. He said, he's the second smartest person in the world on this topic. And I said, I want the best. And he goes, but Dan, I'm not available. So with that, Dr. Jack Jacobs has been my partner. He got his PhD from Washington University, St. Louis. He was at Merck Pharmaceutical. He was at Hitachi Pharmaceutical. He is brilliant. He is honest, but most of all, he's probably the nicest person you'll ever meet in your life. I'd like to introduce Dr. Jack Jacobs to do the hard part of this presentation, the clinical evidence. Dr. Jack, take over.
Thank you, Dan, for that very kind introduction. Thank you, viewers, for joining us for this webinar. My talk, I'm going to give you a little statistics. Then I'll talk about how our drug works, the mechanism, and finally I'll end up with showing some clinical trial data. I'll be talking about how therapeutic angiogenesis, which is growing new blood vessels in damaged tissues, can be used to treat the #1 cause of death in the world. Not only in the world, but in the United States, heart disease is a leading cause of death. 1 in 4 people will die of heart disease in the United States. And this number is actually down quite a bit. 10 years ago, 1 out of 3 people died of heart disease, but Americans are probably exercising more, their diets are better, maybe better medicines, and importantly, less smoking is going on. So that's probably what has driven down these numbers, but still the leading cause of death in the United States. This is prevalence then, prevalence of cardiovascular disease, which is includes stroke as well. You can see up top, this is in the US, these are American Heart Association statistics. You can see actually more men have heart disease than women in red, but actually more women die of heart disease than men. And if you look in the published literature, there are reasons given for this. One, men are bigger babies. They complain more about chest pain and angina. They demand treatment. A woman can tolerate pain better. And then other papers talk about what Dan was just talking about, this microvascular disease, where women often have smaller blockages, and they'll go in for an angiogram and it looks fine, and they're sent home even though they have chest pain, and they might say, oh, you have acid reflux or something. So that is the second main reason. The other thing on this slide, look at this with African Americans. Almost 50% of women suffer from cardiovascular disease. And the reasons for this are not all clear, but it's thought that genetics and also African Americans have a greater sensitivity to salt in terms of hypertension. Now, I mentioned that women have a significant amount of heart disease, and in fact, it is the leading cause of death in women in the United States. And if you ask many women, they would say, oh no, all forms of cancer probably kill more people than heart disease, but this is not the case as shown here. These are statistics from 2018. Let's look at the world in general. This is highest cardiovascular disease rates in the world. This includes heart disease, stroke, and then high blood pressure can also affect other organs and result in death, such as the kidney. But the US is actually 10th out of all countries. And look up here, we have Russia and Ukraine, almost 5 times more deaths in those countries than in the United States. This can't all be due to the vodka they're drinking there. So we think it's probably also has to do with genetics, a lot more smoking in those countries, and probably less exercising. Okay, what are the treatments, current treatments for coronary artery disease? Dan mentioned these, but let me just show you some diagrams. Probably the most common treatment is bypass surgery. And that's done, this person is having a double bypass procedure. And you can see this is the right coronary artery, and it's got a complete blockage right here. This is a left descending coronary artery with a blockage here. So to do a double bypass, to bypass this blockage, they take a saphenous vein, which is in your leg actually. So they dissect out this saphenous vein from your leg, and they attach it here to the aorta. This is red oxygenated blood, so this is good blood to tap into. And they simply bypass this blockage and suture the other end of the vein distal to that blockage. Now, the second type of bypass actually uses an artery that's already there. So this internal mammary artery supplies our chest region, but in bypass surgery, they leave it connected, and then they connect it distal to the blockage here. So here's a double bypass. Blood is going now into the coronary vessels distal to that. So what are the cons of bypass surgery? Well, one, it's incredibly invasive. They need to crack open your chest to do this procedure. Many times they stop the heart and put you on a heart-lung machine. When you come off that machine, sometimes people have loss of memory, and that could be due to minor infarcts in the brain. There's inflammation that can occur to this. Actually, bleeding is a complication. And this procedure becomes more dangerous the older you get. So in people under 65, it's the complication rate, major complication rate is about 5%, but as you get older, this increases. Now let's look at the second most common form of treating coronary artery disease is stenting. Okay, and that's done with a catheter, so it's less invasive. You can insert a catheter into the groin region, the femoral artery, and you come up into, this is a coronary artery with a blockage shown right here. This is a plaque blockage. So you place the catheter right where you have that blockage, and then as Dan mentioned, with the balloon, you blow up this balloon, and it does two things. It kind of gets rid of the plaque here, smashes the plaque, and then leaves this metal stent behind. So you deflate the balloon, you withdraw the catheter, and you have a metal stent. These stents can have drugs on them, drug-eluting stents, which are trying to counteract the main problem with stenting, and that is what's called restenosis, or the artery clogs back up again, okay? And that can occur, some publications say that can occur in up to 40% of people after a 5-year period. The second problem with this is when you smash this plaque, it's got to go somewhere. And if it goes to the brain or to the lungs, you can get blockages there, which can cause additional problems. Now, I showed you statistics where 1 out of 3, 1 out of 2 people would have heart disease. Why do not the rest of us develop heart disease, especially as we get older? It's because we can develop collateral circulation around a blockage. So if we're 65 years of age and healthy and develop a coronary artery block, say in this middle-sized artery, our body makes new blood vessels. It stimulates these new blood vessels, actually by the drug that we're developing, okay? So naturally, when there's blockages, you can develop this coronary circulation, which takes care of the problem. It's only when this process doesn't happen that you develop angina and potentially have a heart attack. So this is basically what our drug does. We're going to be injecting it into areas of the heart that need a boost in their blood supply, that aren't doing it naturally. And we refer to this as kind of a bio bypass because it's a natural bypass. This is done by a process called angiogenesis. We use angiogenesis naturally in our bodies. For example, this shows angiogenesis in a wound bed. So let's say you scrape your elbow, you develop a scab over that scrape, and this is the wounded area. You kind of peer underneath that scab. Here is angiogenesis at work. New blood vessels being formed to regenerate not only the skin tissue, but sweat glands, hair follicles, nerves, and that's all being driven by FGF1 and other angiogenic growth factors. But FGF1 is probably the most potent angiogenic growth factor in our bodies. So we're using that to stimulate what we call therapeutic angiogenesis. And that would be, for example, in heart disease, where the coronary arteries might be stunted or blocked. We could inject FGF1 right into the heart muscle, and 12 weeks later, grow robust new blood vessels in the damaged heart. And I'll actually show you some data, human clinical trial data, which supports this. I'll talk a little bit about our drug, FGF1. Shown here, it's a biological, which means it's a protein, like insulin, like growth hormone. I actually was involved in purifying this a number of years ago when I was a graduate student in St. Louis. So FGF1 is a natural product in our body that can potently stimulate the growth of both new capillaries, which is called angiogenesis, and small arteries, which is called arteriogenesis. So let's look at this process in a bit more detail. This is a slide we took from the Angiogenesis Foundation in Boston. And we're going to look at the beginning of angiogenesis, what initiates it. These are the growth factors. Here's FGF1, and it's going to bind to its receptor, the FGF1 receptor here, shown on a blood vessel cell. Okay, this is on an endothelial cell, which coat the inside of all our vessels. So when FGF1 binds right here, it sets off an explosion of metabolic events leading to the growth of new blood vessels. And they first start off as these little tubules here. They grow into capillaries. And this might be happening thousands of times along this existing vessel. It also can grow slightly larger vessels called arterioles. And these are basically larger capillaries, but have surrounded with these smooth muscle cells, which give it a little bit of a pumping action. So you get better perfusion with these types of arterioles. So FGF1 can stimulate both the production of capillaries and these small arterioles. Now, to understand how our drug works, I want to talk a little bit more about this interaction of FGF with its receptor. As I mentioned, once the FGF binds to its receptor, you get an explosion of metabolic events, which I won't go into, but thousands of published papers have been written on this. But once it binds, it kicks off this process of growing new blood vessels, or angiogenesis. And I'm often asked why, when we inject our FGF1 into the body, why don't we see blood vessels growing everywhere, which would be a disaster. We don't want blood vessels growing in our eyes, retinas, which can cause blindness. We don't want new vessels clogging up our kidneys. So why is it that it only works in damaged tissues? So this is a very important mechanism of our drug. And let's say someone is healthy, and then over time, develops heart disease. We know this occurs over years. And in heart disease, the heart muscle becomes basically starved, ischemic, becomes weaker, and eventually can die. So let's look at heart disease. What's going on with the FGF receptor system in that disease? Well, in normal tissue, normal healthy heart tissue, not much is going on with FGF1. We have few receptors. It's estimated about 100 per cell. Really not enough to kick off that metabolic activity to give us new blood vessels. But over time, as a person develops heart disease, we get this tremendous upregulation of the FGF receptors. And researchers have shown there's about 10,000 of these receptors on ischemic heart cells. For reasons that aren't clear, there's not enough FGF1 to kick off the production of new blood vessels in that disease. So the heart remains ischemic, it remains starved, kind of crying out for more blood vessels to better perfuse its tissue. This is shown schematically on this type of slide. This is in the ischemic heart, 10,000 FGF1 receptors crying out for FGF1, wanting to divide and form those new blood vessels. And we come in with therapeutic angiogenesis. FGF1 is these yellow balls and kick off that process of growing new blood vessels. Okay, I'd like now to review some clinical trial data. Dan mentioned, in my mind, we've had data from 3 trials, 2 in Germany that I'll go over, and then 1 in the United States that I actually supervised and was in charge of. Okay, what's our patient population in these trials? Both men and women. Men tend to come in more with large vessel disease. You can see a blockage here in a major coronary artery. But also, as Dan mentioned, 80% of these men will also have diffuse disease in other parts in the smaller microvasculature. And that's shown on this next slide, which is more prevalent in women, small vessel disease. So here are the women's major arteries. This is an angiogram, putting a dye in the coronary vessels, are pretty much open, but we have blockages in these small distal microvessels as shown here. And you can't bypass a vessel like this. You can't put a stent in there. So really, these are no option heart patients. Really nothing can be done for them, and that's why we're excited and wanted to develop FGF1 as a new treatment for this type of heart disease. Okay, so the trials I'll talk about, the first trial was done in Germany. It was done in people getting a bypass, so it was kind of hard to distinguish what was causing the beneficial effect. But then in the second trial that was done in Germany, it was done as sole therapy. Patients only got FGF1 injected into their heart. And then a similar trial as a second trial was done in the US. That's the one I supervised. Also supervised the second trial, but that was halted, as Dan mentioned, to the recession. Okay, so in the first German trial, they mainly were looking at growth of new microvasculature in the heart stimulated by FGF1. So this is before treatment. This is, again, an angiogram. This is a coronary vessel. Should be more vessels around here. We inject the FGF1 directly into the muscle. 3 months later, you see this robust growth of new blood vessels in the heart. And these vessels are growing 3-dimensionally into the heart, so perfusing that area of the heart, which needs more blood perfusion. And you can imagine if you do this 10 or 20 times, you're going to really increase the blood flow in this heart. Now, the second thing that was learned from this first trial was that these vessels are durable. And so they looked 3 years later to see if these same vessels were intact, and in fact, they were. So this is the first look that I just showed you. After 3 months, we grow new vessels. This is a measure of capillary density. So before treatment, after treatment, you get about almost a 3-fold increase in capillary density where you injected the FGF1. 3 years later, the same situation persisted. This is before they were treated. 3 years later, those same vessels are there. They're perfusing the heart tissue. They're durable. Okay, before I go on to results from the second trial in Germany, I just want to discuss angina, which is chest pain, and angina scoring system. There's 4 classes of angina. Class 4 is the worst, the most severe. You have angina at rest when you're in bed and with any level of exercise. Class 3 is a little bit less severe, but you still get chest pain walking up just one flight of stairs, and you have a marked restriction of your activities. And then Class 2 and Class 1 are more mild. Class 1, only angina with strenuous activity. And so we'll show these different classes of angina as color-coded regions in the results as shown on this next slide. So this is a second German trial where there's no bypass. They just went in and gave FGF1 multiple injections in damaged areas of the heart. And the first readout was angina. Again, remember, this red is severe class 4 angina. Yellow is moderately severe. Green is class 2, less severe. So there was highly significant improvement in angina. So look at the red before treatment, after treatment. Look at the remarkable decrease in class 3 angina, going from here to here. And after treatment, predominance of class 2 and even some class 1 angina. So this is highly significant. These patients are doing much, much better on their chest pain after treatment with FGF1. Now in Germany, they don't put people on treadmills to look at their exercise performance. They put them on a bicycle. So in the second trial, there's also highly significant improvement in exercise performance on the bicycle. So here they're measuring kind of power. They measured it at 45 days and 90 days after treatment with FGF1. 18 out of the 20 patients improved, as shown here. So again, a very significant improvement in exercise performance, which is the main clinical readout that our FDA is looking for in the United States. Now, the third readout from this second German trial was perfusion in the heart, measured by SPEC. And so this measures blood flow in the heart. And basically, more blood flow, better perfusion is in red. And you can see before treatment with FGF1 and after treatment, the increase in perfusion shown in the red area at 90 days. If you put them on a bicycle and do the same type of test, you can see perfusion increasing after 90 days. And as shown here in this graph, 16 out of 20 patients increased blood flow in their heart after treatment with FGF1. So at this point, these are academic researchers in Germany. They published their papers and then went on to other things. But as Dan mentioned, we took this up in the United States. And I was able to supervise the first trial done in the US with FGF1 in heart patients. Rather than show you the data, let me just show you one of our clinical trial sites was visited by ABC News. Dr. Lynn Wagner was the cardiologist at that site. And they interviewed her and our patients because they were doing so well after FGF1 treatment. I just want to show you that video clip.
But since receiving an experimental treatment for his blocked arteries, his pain is gone.
I really feel great.
Duke was one of the first heart patients in the country to be treated with a protein actually capable of growing brand new arteries. The genetically engineered protein is injected directly into the heart. Within days, a network of new vessels begins to grow around the blockage, increasing the blood supply. Dr. Lynn Wagner showed us the changes in one patient's heart.
We see a small, narrow main artery and not very many secondary and tertiary arteries. This is after the treatment. What we're now seeing is new blood vessels growing here off the end of this artery.
And the patients themselves?
Symptomatically, they're improved within a couple of weeks of the treatment.
Just ask Constance Donnelly.
Oh, I feel wonderful. I've never felt so good in the last 5 years.
But doctors already see potential in other cases where the blood supply needs a boost, such as strokes and diabetes.
Okay, so this is just the composite data from that trial, the phase 1 trial, which I supervised. Before treatment, all the patients had either severe or moderately severe angina, either red or yellow. And look at this after treatment. Very significant decrease in the severe and moderately severe angina. We're seeing less severe and even class 1 angina. These people can actually exercise quite a bit without chest pain. So again, a very significant result in improving angina. And putting these people on a treadmill, we look at their time on a treadmill, again, significant improvement after treatment with FGF1. So we're excited about this treatment, and we're going to be moving forward with clinical trials both here and in Europe. Let me just say I got to publish those results in a journal, which was always pleasing. But let me just show you what our next clinical trial is going to be looking like. One difference, we're going to be using what we call commercial grade FGF1, and that means our FGF1 will be made in a FDA inspected and licensed facility. The FGF1 that was used in the previous trials was good FGF1. It was fine for human use, but it was non-commercial grade. And the importance of this will become apparent in 1 second. We're going to repeat that phase 1 study, the one that I showed you, the video. But instead of injecting directly into the heart, we're going to use a less invasive approach. We're going to use a catheter, injection catheter, where again, you can go up through the femoral artery and go inside the heart and inject from inside the heart. And I'll talk a bit more about that in a second. Now, here's the real difference between now and what was going on 10 years ago when that study was done. The FDA has since passed what's called breakthrough therapy designation. This allows drugs to be approved after phase 2. And this is seen with cancer drugs. And this is what we hope to apply with our heart indication. The reason it's important to have commercial grade FGF1 is that you've got to include that in your pivotal clinical trial for approval. So by using commercial grade FGF1 in this hopefully phase 2 trial, we can then apply for approval after that. We can work with the FDA to design a phase 2 study for drug approval. And we're going to use different types of technology than was used 10 years ago. There's more accurate ways to look at cardiac perfusion. And we'll be using a cardiac perfusion MRI as a more accurate readout. Okay, so I mentioned we'll be using a catheter. J&J, Johnson & Johnson makes a injection catheter. We might use this one. We may use another one. But they all work the same. You can use this in a cardiac catheterization lab. You don't need surgery. It goes up through the femoral artery and then comes right inside the heart. Here's the injection catheter inside the heart. Prior to this, the heart is mapped out for regions of ischemia, shown in blue here. And here shows the injection catheter injecting FGF1 into the wall of the heart, as shown here. So this will stimulate the growth of new blood vessels in that area. And if we do that 10 to 20 times in one sitting, which takes about an hour, in 3 months, we hope to see a robust growing of blood vessels in this person's heart. Now, I mentioned we'll be using cardiac perfusion MRI. This is just a colorized schematic of that. This is a lot more sensitive than the previous technologies. I think in red here, we see ischemic heart, and we'll be using this. Most hospitals have these MRI capabilities now, and so it will not be an issue. Now, hopefully, we also, in the future, want to look at FGF1 to prevent heart disease. And that is before symptoms appear, before someone gets chest pain or suffers a heart attack. And that's going to be possible by imaging technology, which is coming on board, which can image ischemia in the heart before any symptoms appear. And that's shown here. This is PET imaging showing an ischemic area of the heart. And this person has no symptoms of heart disease. Inexpensive enough, I think if people have this scan done and see a little ischemia, I think they would probably opt to have FGF1 injected into that region to ward off the more detrimental issues that could come downstream of that, including severe angina or a heart attack. Now, I just want to end on talking about our FGF1 drug and how we make it. None of these clinical trials would be possible without the technology of bioengineering or genetic engineering, as it's called. I mentioned I purified FGF1 from cow brain. You obviously can't put cow FGF1 into a person's heart. In fact, FGF1 is so scarce in our own bodies, it's not even viable to try to get it from humans. So we use our friends, the bacteria, which we grow up in large quantities in this fermenter. Bacteria divide every 30 minutes. And in that bacteria, we have placed the human FGF1 gene, much the same way they make growth hormone and insulin in these bacteria. And I want to show you the power of this technology. As a biochemist, I've been living with these gels. They're called protein gels all my life. I've run thousands of them. And what they simply do, each one of these blue bands is a protein, okay? So we take some bacteria from that fermenter, we kind of crack it open and place it at the top of the gel. We apply an electrical current, and all these bacterial proteins start separating out according to their size. These are large proteins, middle-sized proteins. And look down here, this is our human FGF1 being made in bacteria. We've forced these bacteria to make FGF1 as the most predominant protein in their cells. So the bacteria don't really need FGF1, they don't really want it, but we've forced them to make it as a dominant protein. Now we need to get rid of all these bacterial proteins before we can use this as a human product. These can be toxic, they can cause immune responses. So over a period of weeks, we run different purification steps to whereby we come to the final pharmaceutical, commercial grade FGF1 product, which is now ready for our clinical trials. So I want to thank you for your attention. If you want more information on the clinical trials or want more information on our company, please go to our website, zgm.care. And I'm happy to take any questions now.
Thank you all to the attendees. We've been overloaded with these questions and can only ask a few of them. Our first question is, how do you deliver the drug into the heart?
Okay, so different from that video I showed you, we're going to use a catheter, an injection catheter. So first, the cardiologist will map out the heart, identify areas that need the treatment, that need a boost of the blood supply, that are exact regions, and through a needle, get multiple injections in those areas where the heart needs a boost in its blood supply.
Thank you, Jack. We have another question. How do you make sure the drug stays in the injected area?
That's a good question. We know from our animal studies that when we inject into the heart, actually about 90% of the drug leaves the body within, I'd say, 2 hours. But 10% of it stays in the heart muscle, for up to 4 to 5 days. And that's what's causing that explosion of angiogenesis, that generation of new blood vessels, right where we've put the drug, right in that very localized area. And that's the real reason this heart therapy is working. Lots of companies tried this before we did, but they put it into the coronary arteries or even just intravenously, and the FGF1 was swept out of the body very quickly. So the key is injecting it right into the heart muscle where it's needed.
Thank you. Another question. How does the cost of this drug compare to present procedures?
So we look at it over a 3-year period. How much does it cost to do a bypass and then take care of those patients for the next 3 years, or to give them a stent and then take care of them for the next 3 years? And Dan might have a better figure, but I think our 3-year costs come in about 1/5 to 1/10 the cost of doing a bypass or stenting, which I think the insurance companies are going to love.
All right, another question. What are the long-term effects of this drug?
So we've seen no long-term adverse effects. We hope the long-term beneficial effects are the blood vessels stay there for years and years. We know in the heart they stay there for up to 3 years. We just didn't look longer than 3 years. But in all our clinical trials, we look very carefully to make sure blood vessels are not growing where they shouldn't be growing, such as the eye, kidney, and we also look very carefully for any abnormal growth, say of tumor markers, and we've seen none of that whatsoever in any of our clinical trials. We think this is a very safe drug.
We have one more question for Jack. Jack, how often should this injection be taken?
Well, we hope in the areas that we treat, that those areas will have durable, good, healthy blood vessels for many years. Obviously, we can't stop the disease from reoccurring in other parts of the heart. So if disease does pop up in other parts of the heart and the people start feeling more chest pain, we can go back in and retreat other areas of the heart. So it's possible that people can come in for retreatments, but probably in different areas that were affected in their first injection.
Ladies and gentlemen, thank you for watching this webinar. Now, one of the things that I just want to bring up are, before my closing remarks, our Zhittya will have a webinar on diabetic foot ulcers, Thursday, August 20th. Now, please, if you know anybody who's a diabetic, tell them about this webinar. Jack has just told you about what I consider to be the crown jewel of our drug pipeline. That is the coronary artery disease. I believe we have the ability to treat 2 to 3 million Americans every year and 10 to 20 million people around the world to take them away from suffering angina in their heart and extend their life by 10, 20, 30 years using our heart drug. The second thing that I am most proud of is our treatment for diabetic foot ulcers. In the United States, 7 to 10% of all diabetics suffer from diabetic foot ulcers. There's roughly 30 million diabetics in the United States and Canada. So you're talking 2 million people a year have these ulcers, which if they don't close, become infected and could lead to amputation, which often leads to death. Diabetic foot ulcers to a diabetic is a sword over their head. And this is something that we have had 100% success. You can see the phase 2 data that Jack will present next week. And it is something that people who have diabetes, when they see this, they become hopeful that there's a way to extend their life. That'll be at 8 a.m. Pacific time, 11 a.m. Eastern time, 5 p.m. in Germany, 6 p.m. in Saudi Arabia, and I believe that's also 6 p.m. in Lebanon. Now, the following week, our 4th seminar will be on stroke recovery. Can therapeutic angiogenesis enhance the recovery from a stroke? Now, I'm going to use US numbers. Roughly 1 million Americans every year have a stroke. Roughly a third die. Roughly a third have minor complications, but a third have major complications. It is that third that I believe we can enhance their recovery. Now, we're not talking about the person's having a stroke and we come in quickly and we fix them. We're talking about they have a stroke and after that stroke has settled and the people are diminished. We believe from that point, we can bring them back materially. Now, many years ago, my aunt had a stroke during the night. A vibrant, happy, laughing, fun woman went to bed. And a vegetable was there in the morning. She lived for 15 years, unable to say her name, barely able to eat, not even recognizing her children. Stroke is one of the most vicious and horrible things I can think of. I believe that our treatment can enhance the outcome for that third that have been materially diminished. We can recover their ability to relearn, to recover, to speak, to walk, and extend them so that if they have another 15 years of life, it's as a human and not as a vegetable. Once again, that's going to be Monday, August 24th, 9 a.m. Pacific, 12 noon Eastern, 6 p.m. Germany, 7 p.m. Saudi Arabia. Following that, our 5th webinar is going to be Tuesday, September 1st. It's on peripheral artery disease. Peripheral artery disease is the same as heart disease has clogged arteries in the heart. Stroke is clogged arteries in the brain, but your legs have clogged arteries. It's called peripheral artery disease. 10 million Americans are affected by this disease. Most people think that it's the pain in the legs that is the primary issue, because with a blockage in the legs, there's pain, trying to get blood to the muscles, et cetera, et cetera. I disagree. The legs are the second biggest pumping organ in your body. The heart may push the blood out, but the legs got to push it back. And if the arteries and the legs get weaker, it leads to a whole compounding set of effects. Peripheral artery disease is the third leading cause of that cardiovascular disease. From our animal work, we believe we can treat that. Injections around the blockage, reestablishing perfusion. This is a big indication. We've got great data. And once again, that's on September 1st. My closing comments. The reason we're going through this effort is Zhittya is an outreach program. We're trying to make people aware of our medical science. We're trying to show people there is a possibility to recover from Parkinson's. There's a possibility to enhance the life you have after a stroke. We're trying to show people that just because you have angina and you have small vessel disease does not mean you're going to die. We are trying to get out and outreach to people. Presently, we have 40,000 people registered with us. Over the next 60 days, we will reach out to an additional 1 million people to try and make them aware of what we're doing. We're seeking to develop a network of motivated and informed individuals who can help us make new contacts. One of the things that it came from our outreach program, when we were reaching out to our 40,000 followers, we discovered that there was a professor in Minnesota who had signed up with us on Parkinson's disease, who has developed a way to get our molecule into the brain without the infusion process. Do we know if his science is real? Not absolutely, but what he's shown us is impressive. And if it works, it means that instead of somebody treating Parkinson's or stroke or MS sitting and getting a 1 hour infusion to get the molecule in the brain, it might simply be they take a little snort of a nasal inhibitor in the morning, one in the afternoon, and voila, they're going to be cured in 6-8 weeks. It's a big deal, but this came to us from the unknown, and we've had others I'm not going to bore you with. Now, you feel free to email me on any questions you have. It's dan@zgm.care. Most of you know me, a lot of you know me. A lot of you know Dr. Jacobs. We've been at this 22 years. You guys know that we wake up before the sun, we go to bed long after the sun. We work 6-7 days a week without hesitations. We have, in our opinion, the ability to change the medical outcome for tens of millions, hundreds of millions of people. So let me tell you a secret. Change against the establishment doesn't occur with compliers. People who want to comply with the post office, people who want to comply with the tax authorities, people who want to comply, they don't change the world. To change the world, you need to be two things. And first and most important is a true believer. You have to believe in what you're doing. It is not a sacrifice to do something you know is wonderful. It is an honor. The people at Zhittya, all of us, are honored to have these opportunities. We are making great progress. I believe the next 60, 90 days is going to shock people with how wonderful we got things going, whether it's clinical trials in Mexico or Estonia or in the United States. I believe we're close. So I thank you for your time. I appreciate the fact that some of you have stayed up late. As you can tell, we're trying to figure out what time works best, when is good for so-and-so, how can we try to reach as many people as possible. I can tell you that we are amazed at the response that we're getting, and we thank you. And imagine how much better it'll be when we actually know what we're doing as far as these Zoom broadcasts. We know how to develop drugs, folks, but we're having a difficult time with the Zoom, that you can tell. So we'd like to thank you for being here. We'd like to thank you for supporting us. We'd like to thank you for challenging us. And we pray that you all have a good life, and we pray that God blesses you too. Good day.